Welcome to the chapter on pulmonology. In the first section, I will be providing a basic overview of the anatomy. Let's get started. In order to understand some of the basic anatomy, let's draw the lungs on this blank screen. So this is the right lung, and this is the left lung. Recall that the right lung has three lobes, the upper, the middle, and the lower lobes, and the left lung has two lobes, the upper and the lower. Recall that this segment of the left lung is called the lingula, but it isn't a functional lobe. Right here we have the heart, and then below the lungs we have the diaphragm. And this is the primary muscle that facilitates respiration. Do you remember what nerve innervates the diaphragm? The phrenic nerve. Many students use the mnemonic C345, keep the diaphragm alive, because the roots of the phrenic nerve are C3 through C5. Okay, let's do a quick example. An X-ray reveals an elevation of the left hemidiaphragm. Is the left or right phrenic nerve damaged? Recall that the diaphragm has a right portion called the right hemidiaphragm, like this. It also has a left portion called the left hemidiaphragm, like that. So as we just learned, the phrenic nerve innervates the diaphragm. Remember, when the diaphragm contracts, it's pulled downward and allows the space in the thoracic cavity to increase. If the phrenic nerve is damaged, then the diaphragm cannot move downward, so we'd expect the damaged side to be elevated. In this case, the left hemidiaphragm is elevated, so we know that the left phrenic nerve must be affected. Okay, let's do another example. Why are patients who take TNF-alpha inhibitors at an increased risk of Mycobacterium tuberculosis? Recall that TNF-alpha is normally released from macrophages and helps form granulomas. So this will represent the macrophage. It's releasing TNF-alpha, which helps form granulomas. Remember, a granuloma is a collection of macrophages that forms a wall around an infection and prevents further spread of the disease. So on this side of the image we have a wall of macrophages, and they're walling off an infection. This process is particularly important in preventing tuberculosis, or TB. Remember that TB initially infects the lungs and can then spread to other tissues if the infection is not contained by the immune system. Normally, the immune system responds to TB by forming a granuloma and preventing spread of the infection. However, in patients taking TNF-alpha inhibitors, we can see that the granuloma formation breaks down and TB can easily spread throughout the body. This is because TNF-alpha is responsible for forming the granuloma. So if we block this, the granuloma can't form and the infection can spread to the body. Okay, let's move on to the respiratory tree. This is figure 3.1 from your text, which shows the normal anatomy of the respiratory tree. For step 1, it's important to remember that the respiratory tree can be divided into two parts, the conducting zone and the respiratory zone. The conducting zone is the part of the airway that doesn't participate in gas exchange, and the respiratory zone is the part of the airway that does participate in gas exchange. So as you can see, the conducting zone is comprised of the trachea, the bronchi, the bronchioles, and the terminal bronchioles. Notice that the cartilage is no longer seen as we move from the bronchi to the bronchioles. The respiratory zone is comprised of the respiratory bronchioles and the alveolar sacs. Okay, let's do an example. What genetic disorder results in destruction of the alveolar walls? Alpha-1 antitrypsin deficiency. We'll write A1AT for short. In order to understand this disease, we need to take a step back and understand elastin. Recall that elastin is the stretchy protein in the lungs that allows the lungs to expand during inspiration and recoil during expiration. So elastin, very important protein in the lungs. Elastase is a protein that breaks down elastin, so we'll show it inhibiting elastin. Alpha-1 antitrypsin is the major inhibitor of elastase. So it blocks elastase. So you can see that if a patient lacks alpha-1 antitrypsin, then elastase is overactive and results in excessive destruction of elastin. As elastin breaks down, the alveolar walls are destroyed and patients begin to accumulate air in the alveoli, which is known as emphysema. We'll talk about this genetic disorder in more detail throughout the chapter. Okay, let's move on to the histology of the respiratory tree. This is figure 3.2 from your text, which shows the normal histology of the respiratory tree. Let's talk about the conducting zone first. Notice in the upper airways, or the trachea and the bronchi, that the epithelium consists of pseudostratified ciliated columnar epithelium. Notice that the pseudostratified ciliated columnar epithelium contains cilia. You can see these here. As the cilia beat upward, they move debris out of the respiratory tract and are an important component of the mucociliary escalator. Notice that the goblet cells are also present here, which are responsible for producing mucus, which moistens the respiratory tract and also helps trap particles. The mucus produced by goblet cells is the other component of the mucociliary escalator. Finally, notice that this region of the airway contains basal cells, which act as stem cells, smooth muscle, and cartilage. Okay, now let's have a closer look at the bronchioles and the terminal bronchioles. Notice how the pseudostratified ciliated columnar epithelium is no longer pseudostratified. Rather, it has become simple ciliated columnar epithelium. Also notice that goblet cells and basal cells are no longer present. Instead, these have been replaced with club cells, which are sometimes also called Clara cells. I like to think of club cells as a combination of basal cells and goblet cells. Club cells secrete a mucus-like substance similar to goblet cells and also act as a stem cell for the bronchioles. Finally, notice that the cartilage in this region is no longer present. Okay, before we move on to the respiratory zone, let's do a few examples. What histological changes would occur in the conducting zone as a result of chronic bronchitis? Okay, before we get into the details of this question, why don't I take a step back and explain chronic bronchitis. Chronic bronchitis is exactly what it sounds like. There is ongoing irritation of the bronchi, which results in inflammation. This can be for many reasons, which I'm not going to get into, but the chronic inflammation causes the cells to adapt so they can better withstand the new environment. Let's add figure 3.2 to this slide so you can see what I'm talking about. So generally speaking, chronic irritation to the pseudostratified ciliated columnar epithelium causes the epithelium to undergo metaplasia, or to become a new cell type. In this case, stratified squamous epithelium. When this occurs, the mucociliator elevator's ability to remove debris is diminished because the new cell type doesn't have cilia. The goblet cell will undergo hypertrophy, which will result in increased mucus production. If you think about this, it makes sense. The goblet cells detect the inflammation and increase mucus in order to try and clear out the irritants. Okay, let's do another question. What disease is a result of a defective Dynein arm? In order to understand this question, we need to recall the normal structure of cilia. Recall that cilia are composed of 9 pairs of microtubules. So let me draw out a cross-section of the cilia. So here we have 9 pairs of microtubules. So now let's zoom in on a pair of microtubules as if we were looking at them from the side. So you can see that these represent the microtubules, and this represents the Dynein arm. Normally the Dynein arm contracts and is responsible for allowing the cilia to beat back and forth. When the Dynein arm is defective, the cilia are immotile, which effectively paralyzes the mucociliary escalator and predisposes these patients to lung infections. This is a genetic disorder called Cartaginer syndrome. This is actually very high yield for step 1. Okay, let's move on to discussing the respiratory zone. So again, this is figure 3.2, and now we're going to look at the histology of the respiratory zone. Recall that the respiratory zone is where gas exchange begins to occur. The respiratory bronchioles are similar to the bronchioles and terminal bronchioles, so I'm not going to spend much time on this. Notice, however, that the alveolar sacs look quite a bit different. So here we have a cross-section of an alveolar sac. We can see a number of new cells, including type 1 and type 2 pneumocytes, the alveolar macrophage, and the endothelial cells of the capillaries. For step 1, it's important to remember that type 1 pneumocytes are the cells that facilitate gas exchange. The thin structure of these cells allow gases to freely diffuse across the cell. Type 2 pneumocytes are the cuboidal cells that play an incredibly important role because they produce surfactant, which helps reduce the surface tension in the alveoli. We'll talk about surface tension in more detail throughout this chapter. It's important to know that type 2 pneumocytes are cuboidal and produce surfactant. Finally, alveolar macrophages help clear the debris that manages to get past the mucociliary escalator. Okay, let's do a few questions. How can the lecithin to sphingomyelin ratio be used to determine the maturity of fetal lungs? Recall that surfactant is produced by type 2 pneumocytes, as we just discussed, and is composed of several lipids, including dipalmityl phosphatidylcholine, lecithin, and sphingomyelin. Lecithin and sphingomyelin can be detected in the amniotic fluid and can help determine the maturity of the lungs. Normally, the sphingomyelin concentration stays relatively constant throughout the pregnancy, while the concentration of lecithin steadily increases. Let's graph this out. The y-axis will represent the concentration of lecithin and sphingomyelin, and the x-axis will represent time. The dark blue will represent sphingomyelin, and the green will represent lecithin. So normally, sphingomyelin stays pretty constant, so it looks something like this, while lecithin steadily increases. So again, lecithin and sphingomyelin. You can see from this graph that the lecithin to sphingomyelin ratio steadily increases. For step 1, it's important to remember that a lecithin to sphingomyelin ratio of 2 indicates healthy, mature lungs. So lecithin to sphingomyelin ratio of 2 or greater indicates mature lungs, and a ratio less than 1.5 is predictive of the baby developing neonatal respiratory distress syndrome because the lungs are not mature. We'll talk about the importance of surfactant in more detail throughout this chapter. Okay, we're going to do another question now. What substances increase and decrease the synthesis of surfactant? Recall that steroids are commonly given to mothers who are going to deliver prematurely because steroids increase the synthesis of surfactant. This can help an immature infant more fully develop his or her lungs before birth and can be a life-saving treatment. So steroids like cortisol increase the synthesis of surfactant. It's also important to remember that insulin decreases the synthesis of surfactant. So with this in mind, how do you think maternal diabetes would affect the development of the infant's lungs? Well, in maternal diabetes, the mother has too much glucose in the blood, which crosses the placenta and enters the fetal circulation. When this happens, the excess glucose is detected by the infant's pancreas, so it begins to overproduce insulin in order to normalize the hyperglycemia. The excess fetal production of insulin inhibits the production of surfactant and predisposes the infant to developing neonatal respiratory distress syndrome, or NRDS. So in summary, maternal diabetes results in fetal hyperglycemia, which results in increased production of insulin, which decreases surfactant. This is why the prevalence of NRDS is higher among infants born from women who have maternal diabetes. Okay, let's do another question. What cells would be involved in attempting to remove asbestos bodies? Recall that asbestos are naturally occurring fibrous-like minerals that were once commonly used for various construction projects as well as other purposes. We now know that asbestos is toxic and can cause severe lung damage. These small particles can get past the mucociliary escalator and can be deposited in the alveoli. When they deposit here, they are called asbestos bodies. So asbestos bodies. Recall that the mucociliary escalator is responsible for clearing debris in the conducting zone. But once a particle reaches the respiratory zone, the alveolar macrophage is the main line of defense. So any particles in this region here are removed by the mucociliary escalator. Anything distal to the terminal bronchioles, so the respiratory zone, is removed by the alveolar macrophage. It's important to know that anything smaller than 2 micrometers can get past the mucociliary escalator. So anything less than 2 micrometers. Anything larger than 2 micrometers gets deposited in the conducting zone, and the mucociliary escalator can clear the debris. So in summary, alveolar macrophages would be involved in attempting to remove asbestos bodies. Okay, let's move on to bronchopulmonary and pulmonary circulation. So again, we're going to be focusing on bronchopulmonary circulation and pulmonary circulation. Bronchopulmonary circulation is supplied by blood from the left ventricle, and most of it empties into the left atrium. The pulmonary circulation is supplied by blood from the right ventricle and empties into the right atrium. Let's draw this out so you can see what I mean. So this will represent the heart. This is the right atrium and the left atrium. Let's talk about the pulmonary circulation first. The pulmonary circulation is just the blood supply to the alveoli and includes the pulmonary artery, the capillaries, and the pulmonary vein. As you know, the pulmonary capillaries are adjacent to the alveoli. After the blood travels through the pulmonary circulation, it returns to the left atrium and then continues out through the aorta to the systemic circulation. Eventually, this blood returns to the right atrium. So we'll have this green line represent the systemic circulation, and it returns to the right atrium. So as I said on the last slide, the pulmonary circulation is supplied by blood from the right ventricle and empties into the right atrium. So perhaps it would be better if we drew the pulmonary artery coming from right there. This would represent the right ventricle. Okay, now let's talk about the bronchopulmonary circulation. Blood leaving the left ventricle, so we'll draw left ventricle right here, eventually reaches the bronchial artery. We'll draw the bronchial artery right here in yellow. This is an important blood supply to the lungs because it helps keep the non-alveolar tissue supplied with oxygen. Most of the blood in the bronchial artery empties into the pulmonary vein, which we'll draw here, and this obviously returns to the left atrium. This may seem odd because the bronchopulmonary circulation essentially bypasses the alveoli. Recall that blood leaving the left ventricle goes to the aorta and then eventually goes to the bronchial artery. So as we can see, this circulation appears to be restricted to the left side of the heart. You may be asking yourself, how does the bronchopulmonary circulation get oxygenated then? Well, it doesn't technically get oxygenated. What happens is the deoxygenated bronchopulmonary circulation mixes with the oxygenated blood in the pulmonary vein. So right here. The oxygen content of the pulmonary vein is much higher than the deoxygenated content of the bronchial arteries. So let's draw that out. The oxygen content of the pulmonary vein has high oxygen content, whereas the bronchial arteries have low oxygen content. Because the oxygen content of the pulmonary veins is so much higher than the oxygen content of the bronchial arteries, when these two mix, the overall oxygen content still remains quite high. This means that the mixed blood can travel back to the systemic circulation and still have enough oxygen to adequately oxygenate the tissues, including the bronchopulmonary circulation. It's important to know that a small portion of blood from the bronchial arteries can actually return to the right atrium by traveling through the azygous and hemiazygous veins. And this would represent the azygous and the hemiazygous veins. This is why the last slide states that the bronchopulmonary circulation is supplied by blood from the left ventricle and mostly empties into the left atrium. Here we can see that some of it empties into the right atrium. Okay, with this in mind, let's do a few questions. A researcher is studying pulmonary tissue necrosis in mice. After surgically removing several pulmonary arteries, she notices that the lungs are still adequately oxygenated. Why? Let's quickly redraw the illustration from the last slide. So this is the right atrium and the left atrium. Here we have the pulmonary artery and the pulmonary vein. This is the alveoli, the bronchial artery, and we have the hemiazygous and the azygous veins. Recall that the pulmonary arteries supply blood to the alveoli and are also the primary blood supply to the lung parenchyma. However, the bronchial artery also supplies oxygen to the bronchi and offers collateral circulation to the lung parenchyma. This means even if many of the pulmonary arteries are surgically removed, cross these out, the bronchial blood supply could still maintain adequate oxygenation of the lung tissue and would prevent tissue necrosis. Okay, let's wrap up this section with one more question. How would the resistance of the pulmonary vasculature of a patient at high altitude differ from that of a patient at sea level? So high altitude versus sea level. We'll get into the resistance equation in more detail later in this chapter, but recall from cardiology that resistance equals 8 times viscosity times the length divided by pi times the radius to the 4th power. We can see from this equation that the radius of the vessel is the most important factor that alters resistance. If the radius of the vessel decreases, then the resistance increases. For step 1, it's important to know that less oxygen reaches the alveoli at high altitudes. This ultimately means that less oxygen is in the blood, so patients are hypoxic. Recall that hypoxia causes vasodilation in most tissues, but the lungs are an exception. Hypoxia in the lungs results in vasoconstriction, which is important because it allows shunting of blood to the regions of the lungs that are better oxygenated. So at increased altitude, patients are hypoxic, which results in vasoconstriction, so the radius gets smaller, which increases resistance. So you can see that at high altitudes, patients will experience hypoxia, which will decrease the radius of the pulmonary vasculature and will increase the resistance.